Next, we have a talk by Dr. Paul Varghese, Chief Intervention Cardiologist from Unity Hospital. He will be speaking on conduction disturbances and heart blocks.
So good afternoon, everybody. I feel really sorry for you because it's been a really long session. It's not easy to sit through ECG talks, and this is quite a lot of heavy duty stuff still to come. After Syed's talk, I mean, most of the stuff that I was supposed to speak is already done. I don't know whether to thank him or strangle him in the corridor. I'll decide after the talk. So we'll just recap some of the things that we've already gone through. I have to go with the flow here because many of the things, many of the stuff that's been spoken about is quite repetitive, so I don't want to bore you again with the same thing. But there are just a couple of things that I'll say extra, and one is that let's have a look at this picture. These catheters that you see here, this is what happens in an electrophysiology study. Whatever we see on the ECG is a surface manifestation of the electrical activity of the heart. But here you see three catheters. Where is this? This one right on the top, that sits over the SA node. The SA node activity is not represented on the ECG. So if you can follow this here, this is the SA node, and you don't see the SA node activation on the ECG. This is an important point for you to understand. It's only when you put an actual catheter over the SA node that with an intracardiac catheter that you can pick this up. All this we've already gone through. That even as the atria, the P wave is inscribed, the AV node is already being stimulated. And there are three areas to the AV node. One is the atrio-nodal transitional area, then the node proper, and then the nodohesian. And then the PR interval, as we spoke about, is this is the His bundle branches, and the Purkinje activation. Now, before we go any further, there are a couple of things that I'd really like you to understand. Before you look at an ECG, and this goes out to all the postgraduates as well as the GPs, it's extremely important that as soon as you take an ECG, you must label the patient's name with the time and the date. In fact, mix-ups in the ICUs are extremely common, and during training we had an incredible situation where you had a patient with a dissection of the aorta lying right next to another man who had come with an anterior wall MI. Their ECGs got mixed, and the patient with the dissection was thrombolized, and the man who actually had the anterior wall MI was not thrombolized because he was supposed to be the patient with the dissection. So whenever you take an ECG, even if a nurse gives you an ECG without marking it, tell them, I'm willing to wait, put the name, the date, that's very important. And, pardon me? Correct. I would also include one more thing, symptoms. I usually tell all my nurses, you put the date, time, and the symptoms. What were the patient's symptoms when this happened? Because sometimes you may pick up a first-degree heart block, for example, in a well-trained athlete or a young person who does a lot of exercise, and it has got absolutely no meaning. So please write whether the patient was symptomatic and what the symptoms are as well. I'll just gloss over this. I wanted to speak a little bit about the standardization, but since my topic are the conduction problems of the heart, I would like to tell you that a 1 millivolt current is supposed to give you a 10 millimeter deflection, but this is at a paper speed of 25 millimeters per second. If you run the ECG machine at 50 millimeters per second, instead of one large box, you'll get two large boxes. What happens in this situation is that someone with a heart rate of say 80 will now show an ECG where everything is broad and the heart rate will be shown as 40. I had just such a case about a month ago. A lady of about 50 was brought in by her husband, an engineer, who was very upset saying, my wife has been advised to buy a pacemaker, her heart rate is only 40. The lady is completely bemused because she is absolutely symptom free. So have a look at this. It's not enough to just look at the height, also look at how broad it is. Because if it is very broad, everything gets dragged out and looks slow. So all the QRS complexes will look broad, the P waves will look broad, and once you put the standardization back, you'll find that magically the heart rate exactly doubles. Because it was run at a paper speed of 50 instead of 25. So we spoke about the determination of the heart rate. Do you want me to go through this with the PGs? See, we know that the paper speed runs at 25 millimeters per second. So 5 large boxes would be your, in 1 second it will move 5 large boxes. So this is, so if you have one QRS complex in every big box, your heart rate is 300 per minute. If it's once in every second box, it means half of 300, 150. But the easiest way would be to just take this distance, and 1500 divided by this distance will give you the heart rate. One more thing that is very important for postgraduates to understand. Normally when we talk of a pulse, we feel someone's pulse and say someone's heart rate is so and so. But when you look at an ECG, what we are talking about is not just the QRS rate. You have to think in terms of what is the P rate, what is the QRS rate, because that gives you, that is how you know whether there are blocks or not. So it's very important that every P should be followed by a QRS. So the question that you should ask yourself is, when you're looking at the rhythm, is there one-to-one conduction? I may look like a bit of an idiot doing this, but it's important. So this is the P wave, let us say. P wave contraction, ventricular contraction. So for every time I do this, I've got to do this once. So suppose you're like this. That was a dropped QRS. That's an important thing to remember. The other important thing that I'd like to tell all students is this. Always look at all the QRS complexes, the morphology. Forget this is an ECG. Suppose you think this is a picture, a cartoon of hills, and I've drawn hills like that. Does this hill look exactly like this hill? It's an important thing, because sometimes you may have two humps on this. That may be a P wave hidden in here. Often when I start teaching nurses and you ask nurses to look at the ECG and you say, is this complex the same as that? And they say, yeah. But if I were to draw a building like this and another building like that, you'll immediately point it out saying this building is not the same as this. So there is an order that is to be followed when you interpret an ECGs. You're looking at the P, you're looking at the QRS, you're looking at the P, the ST segment and the T wave, and make sure that this and this they all look the same morphologically. It's also important to recognize the forest for the trees. When you look at an ECG, your first look should be to see the forest. You have a broad look. Then you hone in on the individual trees. You should have this ability to do both. See the forest for the trees and see the, but you should not miss the trees for the forest, if you understand what I'm trying to say here. Now this is determination of heart rate in a case of atrial fibrillation. This has not been gone through. This is one of the common questions in the MD exam, so it may be worth going through this. Most ECG papers will have a marker here like this. And this measures 15 boxes. Okay? So you count the number of boxes and this is 3 seconds. When you take 15 large boxes, because 1 second is 5 big boxes. So you find the complex that coincides with these are all written at the bottom here. You count the number of complexes in a span of 30 large boxes. So 30 large boxes will give you 0.6, because each big box is 0.2. Then you multiply the number of complexes within 30 large boxes into 10. That will give you the rate in 1 minute in atrial fibrillation. Is that clear, or should I go through that again? Now this is left bundle branch block, but before we go through that, I think I'll just skip back to that first picture. This is an important picture for you to understand bundle blocks. Forget about this rabbit ear, this ear is bigger than that ear. That depends on whether the rabbit is like this or like this. You have to understand basic physiology, cardiac activation. Then you will be able to understand bundle branch blocks better. So the most important thing you have to understand is once you get to the AV node, I'll just elaborate a little bit about the AV node. What the word that you should use for the AV node is the conduction across the AV node is slow and decremental. Slow means, it does slow down here. It is necessary because, as Dr. Syed said, it is very important because if both the atria and the ventricles contract at the same time, it's much like trying to bag somebody with a tube as he's breathing out. That it doesn't work. So your atria when the atria contracts, your ventricle should be relaxing. This is the way the heart beats. So that is the function of the AV node. When I do this, if I do both at the same time, the atria and the ventricle contract at the same time. So I have to do this, wait for a while for the ventricle to fill, and then the ventricle contracts. So there are two purposes served by the AV node. One is to make sure that ventricular filling is optimal. The second is that this is an insurance against atrial fibrillation. For example, if your atria beats at 600 times per minute and all of them were to come through into the ventricle, you will have a ventricular rate of 600, which is not compatible with life. So this is your insurance against death from atrial fibrillation. That is the role of the AV node. It has got multiple properties. If you try and speed it up initially, it will actually conduct faster. Conduction across the AV node actually becomes slicker initially. But when you give steady rapid pacing at a certain point in time, the AV node will start fatiguing. When you put catheters, in an electrophysiology study, for example, if you put a catheter here, it will measure the far field atrial activity, the bundle of His, as well as the activity from the far field ventricles. Now it's plus you'll have catheters here as well. And that is how you know where exactly the blocks happen. Yeah, so the most important thing here is the first vector of depolarization is from left to right. And you must remember that V5, V6, 1 AVL, etc., they're sitting here. So that's the reason why you will see the small septal cues in V5, V6, 1 and AVL. This is the reason, because the initial activation is from left to right. It's going away from those leads. And then the final activation is towards this way, towards the left ventricle, because the forces of the the LV thickness is much greater than the RV, and so the RV activation gets drowned in the electrical forces generated by the left. Why is it that the left ventricle is thicker? Because it's pumping against the aorta or into the aorta, whereas the RV is a low pressure chamber pumping into a low pressure system, which is the PA. So in this, after understanding this particular activation picture, I'll go straight to right and left bundle branch blocks first. So in left bundle branch block, here's another important thing. This term block is can often be confusing. It immediately conjures up visions of a complete cut in the way in conduction. Sometimes it just means a delay. In fact, I prefer left bundle branch delay and right bundle branch delay. Sometimes it may be a total block, but often it's just a delay. For example, let us say this is my right ventricle, this is my left. For all practical purposes, they contract together. But suppose this is a little refractory and it's not as good at conducting the right compared to the left. What will happen? The left will contract first and then the right. So this is not actually a block. It is just a delay in conduction down the right. So in a left bundle branch block, that septal vector is lost. So what happens on the ECG? Your septal cues, V5, V6, 1 AVL, those cues will disappear. You will not see that. And the terminal forces, so now what happens is the right ventricle gets activated first, and then it has to cross the muscular septum where there is no Purkinje fibers, which is why your complex broadens out, and then it accesses the Purkinje system and the terminal forces go this way. And that is why in V5, V6, 1 and AVL you get tall R waves. That initial small little bit that you see here, many ECGs if you watch of left bundle branch block, you will find this is quite narrow. And that is because this initial activation of the right ventricle through the Purkinje fibers is represented by this tiny R. So initial activation is normal, and then terminal activation becomes broad as the impulse plows through all these from cell to cell to cell, and then gets into once it reaches this area, it becomes faster once it gets into the Purkinje system. And this is right bundle branch block. Obviously, when you say right bundle branch block, understand it this way. The left side gets activated first. This also tells you where ectopics are coming from. Say for example, you have an ectopic with an RBB morphology. What does it mean? It means that it is originating from the left side. Okay? And similarly, if you get a bundle branch block with the left bundle branch morphology, it originates from the right side, because the right side gets activated first and the left. Does that make sense? You understood? Now you come to the fascicular blocks. Now mainly there are 3 fascicles actually, but nobody talks about that septal cue that I spoke about is through a septal fascicle, but the ones that broadly you can just remember it as 2. There's a superior fascicle, that's the inferior and posterior fascicle, and the right. So when you say left bundle branch block, it means that 2 fascicles are already involved. So it's already a bifascicular block. A left bundle branch block is a bifascicular block. If you have a right bundle branch block plus one of these, it is still a bifascicular block. So suppose you have involvement of this plus that, bifascicular block. Involvement of this plus this, bifascicular block. If you got involvement of this, this and this, trifascicular block. Suppose you have this and a prolonged PR. The implication would be that the third one is also damaged. I still haven't got to my...
So you have 5 more minutes.
Okay, so now this is mobitz, this is first degree heart block. Okay, now the PR interval is, this is usually at the level of the atrium or the AV node. The AV node has got a lot of sympathetic, autonomic input, both sympathetics and parasympathetics. But both are equally balanced in the AV node. Whereas in the SA node, the vagal tone usually predominates. So this is a situation where with the first impulse gets delayed, the second gets more delayed, third gets more delayed, and then you have a, I'm sorry, I'm talking about the mobitz type 1. This is just prolonged, constant PR. I'm very sorry. 0.26, 0.26, 0.26. It just takes a little longer than usual first degree heart block. Okay, but every impulse gets through. For every atrial beat, there is a ventricular beat. Only thing is it's a little slower. Now you come to mobitz type 1. This is not the same as first degree heart block. Here you have a situation, that's what I was talking about, where you see it takes a little longer to get here. This is a even bolder black line, so it takes still longer, and finally you have a drop beat. Much like a student who comes at 8 o'clock on the first day, the next day he comes at 8:30 because he's lost the keys to the house. Third day he says he comes still later, I missed the bus. Fourth day my grandfather's getting married. Fifth day, boom, he doesn't turn up. So that is mobitz type 1 or Wenckebach. Now this is an important thing for you to understand. This is what's called a syncopated rhythm. It's typically seen in mobitz type 1 or Wenckebach kind of block. You get what are called group beats. So if there are two people standing and talking, two people here, another two standing and talking here, another two here, another two here. This is group beating. It's typical of type 1 Wenckebach. And for that you've got to look very carefully at you see that there is a drop beat here. And here the PR will keep prolonging before a beat drops. Then you have mobitz type 2. This is a more serious malady. The first day he comes at 8 o'clock for the class. Next day he doesn't turn up at all. So it's very hard to entrust anything to this particular student because it's a more serious problem because he gives you no warning. He just doesn't turn up one day. That is mobitz type 2. Now the implication of mobitz type 2 and type 1 is that this is usually confined to the AV node, whereas mobitz type 2 is infranodal. Infranodal can be either in the bundle of His or the Purkinje fibers. So that's a more serious kind of block. It can progress to complete heart block. And complete heart block is where you have a complete dissociation, where the P waves are marching at their own pace and the QRS are marching at their own pace. So the RR intervals will be the same, will be regular. The P to P intervals will be regular, but the QRS rates will be slower than the PP intervals. So there is no communication between the two. It's important here to talk about AV dissociation. What's the difference between AV dissociation and complete heart block? The difference is that if you take a long rhythm strip and you keep following it, you will find some captured beats at some point if it is in a situation where you have AV dissociation. But complete heart block, there will never be a capture. So this is an example, and the QRS duration is also important. For example, if you have a situation where you have the second degree mobitz, but you find that you have a narrow QRS, it means that your problem is above the Purkinje fibers and the bundles. It's a more stable rhythm, or rather a more stable escape focus than the distal escape foci like the bundles and the fascicles and the muscles like an idioventricular rhythm. So here, for example, you have a broad QRS. So let us say for example, you have someone with a type 2, where without warning you get a drop beat. But in one situation you get a narrow QRS. That is nowhere near as bad as a situation where you have a broad QRS, because that implies that you have distal conduction system disease, and this patient may progress to a situation where he needs a pacemaker. So, so another simple way of remembering this is first degree heart block, all impulses get through. Second degree the mobitz type 1, you have some, not all get through, some do not get through, and with third degree none of them get through. These two are not that bad, the worst. There any doubts? So, pardon me? You want me to do that again? Yeah, that is, most ECG papers will have this marker, and every 15 boxes you will get that. So, every 15 boxes will be 3 seconds. You take another 15 boxes, 3 plus 3 will give you 6 seconds worth of time. So, you see the number of complexes that you get in over a period of 30 boxes. That is actually 0.6 seconds. So, that that is 6 seconds, because each large box is 0.04 and 0.2, right? Each is 0.2, each big box. So, if you multiply what you get over 30 boxes into 10, it will give you the heart rate over a minute. Yeah. Correct. Can happen in the atrium as well. It can happen anywhere.
Anywhere. So
it can happen anywhere.
When you investigate that case, what are the situations?
Okay, clinically I'll give you which one are you talking about? Type 1 mobitz or type 2?
I am saying about first degree AV block, which does not always mean AV conduction delay. It sometimes means delay below the AV conduction, AV node.
Yeah. You are talking about first degree heart blocks where you just have a prolonged PR.
Say 0.28.
Yeah, it doesn't mean anything. I'll tell you, it may be a person with good vagal tone. One way of very easily resolving the tissue would be to put him on a treadmill. And if you find that, I told you with the initial bit of exercise, actually the conduction across the AV node can become slicker with a normal node. And once your sympathetics start predominating over the vagal influences, you will find that the PR may actually shorten. Or you can give atropine. So these are two ways in which you can easily.
An asymptomatic patient come with a heart rate of pulse rate of 48.
Yeah.
ECG shows a complete heart block.
Yeah.
The patient is totally asymptomatic.
Yeah.
You want to improve it, or we can?
The important question here is there structural heart disease or not? Now you have a lot of patients with congenital complete heart block. Okay. Yeah, everything may be normal. This may be a person with a congenital complete heart block. Many of them do have some degree of reserve. If you put them on a treadmill, you will find that the heart rate may go up to 97 to 100, but not really much more than that. Most of these people are asymptomatic through the first couple of decades of life. But now lots of studies are showing that many of these patients, if you follow them up for 30, 40 years, they do progress to higher grade blocks. Some of them even have sudden death. It may even be related to the Brady-related ventricular arrhythmias. So there is a school of thought which says that these people should actually be paced as they get older. Apart from that, you can have people with complete heart block which may be acquired. Again, if it is acquired, you've got to decide, is this a hypervagotonic syndrome? Say for example, someone who's having a neurocardiogenic syncope. You can even get a complete heart block. But one clue there would be that you have sinus slowing plus evidence of disease in AV conduction from the AV node downwards. So that is a very good clue to say that it is because of a hypervagotonic situation. They'll also give you a history of multiple faints dating back to 10 years, 15 years often. And you find that they're absolutely normal and they're structurally no problem. So if actually they had structural heart disease, nobody is going to survive that long. So in some ways, if someone comes and tells me I've had multiple faints over the last 10 years, otherwise I'm absolutely fine, it's quite reassuring, because it makes it quite likely that this young person, what he has is probably a hypervagotonic syndrome. Of course, you can do a tilt test to try and tease it out.
Thank you, sir. I request Dr. Yusuf Kurte, interventional cardiologist, Indian Hospital, to present a certificate of appreciation to Dr. Paul.